Our second present speaker is Dr. Prudence. Dr. Prudence is the current president of Philippine Society for Gynecologic Endoscopy and the vice president, Philippine Society of Climacteric Medicine. She is also the head of Manila Central University Hospital and also members of St. Luke's Medical Center and Quirino Memorial Medical Center. And today, Dr. Prudence will be also sharing with us for her experience of hysteroscopic shaving techniques. Please, Dr. Prudence.
Good afternoon. Thank you, Professor Lee and Professor Long, for the invite, and thank you, Dr. Attilio, for the comprehensive discussion on use of hysteroscopic intrauterine morcellation. So I have a disclosure. I received honorarium as a speaker for a JCS Pharmaceutical Company, which is locally based. So since the start of the pandemic, we surgeons did not do any work in terms of elective surgeries. All resources had to be focused on to combating this pandemic. But recently, next slide please, we've been allowed to do surgery. So recently, we've been allowed to do surgery. Next please. Elective surgery at that. And most of the cases that we have started to do have dealt with the abnormal uterine bleeding, which was the common complaint to us during the lockdown period in my city. And they were mostly due to submucous myoma and polyp that could not be helped with medical management. So this afternoon, I chose to speak on the emerging appeal of hysteroscopic shaving of intrauterine pathologies during the COVID-19 pandemic. So nowadays, not only are we concerned about minimizing the risk for the patient, but also for the surgeon. And so that ambulatory surgery, daycare surgery for hysteroscopy is very appealing because, next slide, it's because it's less expensive, there's no overnight stay in the hospital, no risk of VTE, less anxiety for both the surgeon and the patient. So hysteroscopy has been considered the gold standard procedure for treatment of intrauterine pathologies. And ACOG in 2018 put forth 2 ways to remove pathologies: traditional resectoscope and intrauterine shaver, which Dr. Attilio talked about. Next slide. Okay, so Cooper et al. In 2015 put out a guideline on which type of instrument you should use in certain pathologies, like polyp if they're small, less than. Whoops, go back, please. Back slide. Slide before. So for polyps that are less than 0.5, you just use scissors. But if they're getting bigger, you can use your hysteroscopic morcellator or a resectoscope. So when I say bigger, there'll be a plus size of 0.5 to 1.5. For leiomyoma, G0 small, less than 1.5, non-fundal location, the choice given are either a bipolar energy or a morcellator that are small in diameter. But with small myoma that are G1, less than 1.5, the recommendation is to use your mechanical scissors and your bipolar instrument. All right. So for the small myoma, for the myoma that G1 is larger, 2 centimeter, they're noted to have vascularization. That's why the recommendation is to do them in the OT under regional anesthesia using a resectoscope. And for the larger G1, 5 to 6, as well as your G2 myoma for CMs, the recommendation is the same. Do it in the OT with the resectoscope. Now, all right. Oops. Right. So which then do we use? We have to find out the advantages and disadvantages of both. As mentioned earlier, the advantages of hysteroscopic tissue removal system are that there's shorter operative time because as you perform the procedure, you're actually removing the resectate. And there's a higher likelihood of completing lesion removal for polyps. Next slide. For polyps, type 0 or type 1 leiomyoma. Next slide. And the disadvantages are that they lack the electrosurgical element that will control bleeding. And it has been found out with limited data that it is difficult for your morcellators to remove a FIGO2 type of submucous myoma, such that it is the resectoscope loop that is recommended, especially that there is a cold loop procedure. For us to perform these procedures in our country, we had to look at guidelines. So my society, PSG, came up with a guideline early in March, but we did not recommend doing a big surgery during the pandemic because these, we found them to be, most of them were non-urgent cases. We also looked into guidelines coming from AAGL and SK, putting forth some issues that we needed to resolve during performance of the procedure. And my society came up with another guideline in July 6th of this month, where we outline what we can actually do during a procedure when in the event that we are allowed to perform elective procedure. Next slide. Right. So one statement that struck us was the one given by SK on the April 16, 2020, where they centered on hysteroscopic surgery. And it is mentioned here that elective surgery during operative hysteroscopy does produce some surgical smoke. But the surgical smoke produced here are either low or absent because of the following reasons. They're confined in the uterus, and it is released through the outflow into the suction device, and it is rapidly absorbed by the distension medium or into circulation. And also note that they do recommend using the hysteroscopic tissue removal system as mentioned by Dr. Attilio because they lack the surgical smoke formation. Next slide. Early this month, July 8th, the PSGE had a webinar centering on hysteroscopy. And one of our young colleague, Dr. Angel Tan Espiritu, spoke on energy devices during hysteroscopy. And she mentioned something that we never thought really happened. We never thought about it except when she put it out. And she mentioned that during hysteroscopy, smoke is produced because we can actually smell it. Next. So what is surgical smoke? Surgical smoke is an unwanted byproduct of surgical, electro, or laser cauterization. It is produced by deliberate burning of tissue in order to prevent or stop a patient from bleeding during surgery. So in the operating room, nurses often complain that they smell smoke and they can see smoke. Sometimes they don't see it, but they can smell it. So surgical smoke is both visible, and the other components of the smoke are gaseous byproducts. And the gaseous byproducts are composed of water, chemical, particles, both biological and physical. And they are considered to be hazardous for the patient and the operating medical staff. Next slide. All right. So going back to the webinar we had in July, it got to thinking, why is it that we in our country smell smoke, but Dr. Attilio doesn't smell smoke? So I next slide. I made a simulation study on the surgical smoke appreciation during an operative hysteroscopy in the OT just a few days ago. So the aim of my study was to determine the presence of surgical smoke through the sense of sight and smell in a human breathing zone in a simulated workplace. Operative hysteroscopy by a surgical team wearing a surgical mask. I had no aerosol spectrometer, so I just relied on senses of my participants. Next. These were my materials. I had a do-it-yourself pelvic tuner box, which represented the patient. And then below, you'll find that the specimen I used is a porcine bladder, which idea I got from my mentors, Dr. Fong Yok Fai and Dr. Ing Wu of the NUH back in 2013, where they taught me how to create a pathology using a porcine bladder. And thank you to Storch for providing me the setup, the tower, and the machines, and the instrumentation using IBS and resectoscope. Next slide. So the experiment setup is like this. So I had a surgeon, which is about 2 to 3 feet away from the person represented by the PPT, and about a meter away was a surgical staff. And in the PPT head, I inserted a scope so that we could observe if there was any smoke coming out during the procedure. So the first part of the experiment was using the IBS. During the procedure, we did not see any smoke coming out in the screen, and neither did the surgeon or the staff smelled smoke. So the part 2A of the procedure was we use a resectoscope with a tight cervix. Now, when the resectoscope, during the procedure, as long as the scope was inside the cervix tightly hugged, we did not see any smoke coming out, neither did my surgeon or the staff smell any smoke. But when resectate was removed, the surgeon and the surgical staff started to smell smoke, but only mild in intensity. Part 2C of that experiment was we removed the entire resectoscope. Smoke was still not seen, but it was smelled with moderate intensity. So we waited for 20 minutes. We stopped the experiment to allow the room to be cleared of smoke. So after 20 minutes, we went back and put up a setup. So this is the part 3 of the experiment. In the part 2 experiment, we still used the resectoscope, but this time we had a cervix that was loosely fit. And there was a chamber placed over my box, which the box representing the patient, and the chamber representing a container that will contain surgical smoke. And this was at the invention of a young colleague, Dr. Rica Baltasar. So we proceeded with resection. During the resection, because the cervix was loosely fit, the surgeon and the staff smelled smoke, but in mild intensity. We did not see smoke during the procedure. When the resectate was removed, still no smoke was seen in the box, but the smoke was still smelled by the staff, the surgical staff, in moderate intensity. And when the entire instrument was removed, the resectoscope was removed, the staff still smelled smoke, but still at the same intensity, moderate. Maybe because the container, the chamber, was still in place. So the findings of this study is that there is no surgical smoke production with the IBS during an intrauterine morcellation of submucous myoma and polyp. No smoke was also visibly appreciated when the bipolar ESU was used in operative hysteroscopy because of an efficient automated suction system. Number 3, non-visible surgical smoke is produced when the bipolar ESU was used but it can permeate the OR. Hence, it was appreciated through smell by the surgical staff. If the cervix is not snugly fit over the diameter of the hysteroscope, the invisible surgical smoke can still escape from the uterus during resection, removal of resectate, and when you remove the entire resectoscope. And the fourth finding is that surgical smoke permeation into the operating theater can be minimized if the cervix snugly fits the outer diameter of the resectoscope. And if you happen to have a wide, loose cervix, you can actually just make it fit by using a clamp around it and use a chamber over the bottom part of the person and use an automated evacuation system. And we also noticed that even if the staff wore a surgical mask of N95 grade and higher, surgical smoke was still appreciated. So, to answer the statement, the emerging appeal of hysteroscopic shaving or intrauterine pathology during the COVID-19 pandemic in the Philippines, it's very appealing because it can be done on ambulatory day surgery setting, as mentioned by Dr. Attilio. It's less expensive, faster recovery, and the fasting operating time because there is a simultaneous removal, extraction of your tissues that are resected, and surgical smoke is not produced. Next, please. But in the current setting in the Philippines, we still have the electrosurgery as part of our armamentarium during operative hysteroscopy. So these are the practical measures that I came up with. That to minimize surgical smoke escape into the operating theater, you must have a chamber over the bottom of the patient, preferably with an attached ultrafiltration mechanism with suction system, as designed by my colleague, Dr. Rica Baltasar. And B, you should, prior to removing the resectates, you have to allow a few minutes for the smoke to be evacuated by the suction system and make sure that the cervix tightly hugs the resectoscope. COVID or non-COVID pandemic times, the best practice really is to prevent possible infection transmission not only to the patient but to the surgical staff during the hysteroscopic procedures. And these are done by proper room filtration and ventilation, appropriate PPE, smoke evacuation devices with suction and filtration system, and a chamber to contain surgical smoke in cases where you have a cervix that is loose and not tightly hugging your resectate. So I'd like to thank my surgical team, Dr. Rica Baltasar, the chamber inventor, the Xavier Mid Devices staff, Carl Storrs Philippine staff, Dr. Lawrence de la Cruz, Dr. Miss Carissa De Leon, and my videographer, my sons, Cholo and Pia. Thank you very much.
Thank you for Dr. Prudence for your sharing. And now let's see the questions we have from audience, and we still start our second Q&A sessions. And here I have one question about the for Attilio about did you use the mesotrax in the treating the residuals, the gestational tissues in the uterus before the hysteroscope surgery?
No, I don't put any kind of medication.
Yeah, can you hear me, Attilio?
Yeah, I listen you. Could
yes.
you hear me?
Okay.
Could you hear me now?
Yeah.
Okay.
Yeah, yes,
No,
I can hear you.
Hi. I don't
Yes.
use any kind of medication to prepare the cervix before dilatation. Honestly, I have no experience with misoprostol before for ripening of the cervix before dilating it. So we don't use any kind of this medication.
Okay. And here have another questions about the if they have a columnar located RPOC, do you recommend to have a Veda HCGs, and when and for how many times you have used for the check-in for the Veda HCG?
Honestly, there are no guidelines specifically for this kind of situation. More Cornwall is the retained product of conception. Probably better is to wait longer time before removing it. So we can check more than with the beta HCG. It's better that a good sonographer can evaluate the vascularization of the retained product of conception. And if it's highly vascularized, in this case, we treat little bit as an ectopic pregnancy, and we use one or multiple injection of methotrexate.
You means you still have some medications with the methotrexate before the surgery or after surgery?
No, I don't use.
You don't use, and so and what is the what about the dose? The dose you have used the methotrexate you have mentioned about.
The same dose that we use for ectopic pregnancy, so related to the weight of the patient. So there is a mathematical rule that you have to follow, but it's the same dosage that you use for ectopic pregnancy, the same one.
Professor Spiezio, here in China, we usually apply the mifepristone and MTX if the concentration of beta HCG is rather high and some risk for bleeding exists. Then some preparation for application of MTX or mifepristone will make the procedure, hysteroscopic procedure, have better effect for controlling the bleeding during procedure.
Oh, very good. So probably I missed the question because I thought that you were referring to the misoprostol before for the cervix, but mifepristone before doing the surgery, I've never used, but because I know that all of you are very skillful, so it's something that I will try in my clinical activity.
Okay, let's have another questions about the and from the Prudence is Attilio.
Yes.
May I know your tips on how to keep?
Okay, to the surgical smoke produced.
Hysteroscopy.
Yeah. I always connect. I use always the Endomat, the last version of the electronical irrigation and suction device. I always connect the outflow channel to the suction part of the machine, and this is the best way to avoid that, to have problem in terms of dissemination of the virus, and the surgical smoke can completely go out of your resectoscope or your device without any problem. So I always have activated the negative pressure on the outflow channel.
Okay, good. And a question for the Prudence. And Dr. Aquino, is there any plan to factory produce the chamber that you have your junior colleagues have designed it for mass use?
Oh,
Dr.
well,
Aquino, yes.
if she has designed for mass use, we need to ask her. She's still she's just in the trial stage, see how it works. So after the experiment on my box, she plans to put it on a live person and see how it works, and how big her chamber should be to make sure that no surgical smoke escapes. Thank you.
Okay, yes. So we are waiting for.
Yes, I'll ask her to work on it, Dr. Rica Baltasar.
What will be your suggestion setting of the session for hysteroscopy of the 5 French the instrument?
Millimeter office operative hysteroscopy. I connect
Yes.
the suction to the outflow channel of my hysteroscope. Generally, I only use the standard negative pressure without any activation of the suction on the machine. But if I need little bit of suction, I use 0.2 bar.
And also the Dr. Prudence, you can directly ask your question as your audience is on. Yes.
Sorry,
Yes.
I can
And
ask my question.
okay, you can ask your questions because
Oh,
yes. Okay, please.
it's for Dr. Attilio. Dr. Attilio, you mentioned that you don't consider hysteroscopic procedure as a smoke-producing procedure. I wonder what are your techniques, because in the Philippines, really, we appreciate smoke when you do procedures, hysteroscopic procedure. We can smell it. The only thing I can think of that, yes, sir?
No, the problem is that I did some. I read many papers written by Martin Farrugia. There is also a letter to the editor on the last number of Facts, View, and Vision in Obs and Gynae, in which is clearly explained why, even if you produce bubbles in hysteroscopy using surgical smoke generating device, however, the bubbles collapse immediately in the water. Both, there is a difference between the small bubbles and the big bubbles, but they go immediately in the water distension medium. And if you connect negative pressure to the outflow channel, you don't have any bubble coming out from the cervix of the lady or vagina and going in the atmosphere. This was the concern at the beginning for the COVID-19 pandemic, that some bubbles can go out of the vagina, popping in the atmosphere. And so this is the problem, is that if the virus was inside this bubble and the bubble went to the atmosphere, collapsing the bubble in the atmosphere, you could have an aerosolization of the virus. But Martin Farrugia did his PhD on the electrosurgery and hysteroscopy, clearly demonstrated that the bubbles are collapsed, are diluted inside the water distension medium. And if you connect negative pressure on the outflow channel, or all the soluble and insoluble particles are washed away from the cavity, and there is no risk of releasing any virus in the atmosphere.
Yes, yeah. Thank you for that. That's exactly what I thought of. That if you have a
Yes.
nice system that will evacuate completely, then you will have no room for aerosolization. But it
And
comes to
even
my
because
mind.
in endoscopy, you don't use any spray or any coagulation that are more aerosol generating procedures. In hysteroscopy, we are working in an unique environment, which means underwater, that is completely different from what happened in laparoscopy or in laparotomy, or when you do loop surgical electro excision. So it's
Yeah.
a unique environment. We are working underwater and we use only vaporization. So wherever you produce bubbles, because you produce bubbles, these bubbles, even in terms of terminology, you cannot call bubbles. They are
Mhm.
cavity because they have only one surface, but they collapse into the water distension medium. The steam condenses, and so all the soluble and insoluble particles present within the bubble, the cavity, so they are washed away from the cavity.
Yeah, thank you for that, sir. I was just wondering, some urologists,
Yes.
they came up with a study in
Yes.
2009, with Dr. Weston, where they had a gas fumes coming out when during the procedure, and they detected this to contain carbon, hydrocarbon. So I was wondering, maybe the difference that we have a more efficient evacuation system than the urologist.
Really, yes, because the first devices the company have developed the modern resectoscope, mostly modifying the outflow channel and the outer sheath of the resectoscope. If you compare your resectoscope with those of urologists, mostly for the outer sheath, and there is an increased number of holes in the tip of the resectoscope in order to have a better aspiration and a better continuous washing of the cavity.
For our system, yes. Thank you very much, sir.
Yes. 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 Thank you. And I have a last question about the for the Attilio. What is your experience on the removal of the submucosal myoma with a shaver? It seems take time. It takes ages to remove the fibroid by a shaver. What's your experience, and how large is the size you remove the mucosal myoma by the shaver?
To be honest, when I have a myoma, I prefer to use electrosurgery. In this moment, the myoma needs to be small. Honestly, even
Yes,
the removal, the perfect removal of the intramural portion of the myoma, personally, I think that is more effective with the loop rather than with the shaver. If the myoma is small, you have 1 centimeter, 1.5 centimeter, total intracavitary, you can use the device, the tissue removal device, the shaver to remove. But personally, I don't think that the myoma is the main indication for the morsel
Shaver.
linter, shaver or tissue removal device, more generally speaking.
yes. So you favor use the shaver on the polypus of the conception
Poly,
tissues in the uterine cavity. Is that right?
yes, and we are using more that now in the last periods to
Yes.
do a sort of
Yes.
visual DNC
Yes.
when we have thick dishomogeneous endometrium rather than doing multiple biopsy with 5 French
Yes.
forceps that most of the time the specimen can be inadequate. We do a sort of curettage under vision
Yes.
using the tissue removal device, and we do what we call visual
Yes.
DNC.
Mm-hmm. Truly, see.
Yes. Yes. I think that's a good way and a good method in the diagnosis of the pathologies in the uterine cavity. Yeah, I think that's a very good experience.